Hi, I'm Navpreet Dhillon. Welcome to the first edition of Forks and Things, a new initiative sponsored by the AAST Associate Member Education Committee, where we provide overviews of trauma algorithms which you may use in your clinical practice. We are reviewing the updated guidelines to reduce venous thromboembolism in trauma patients, a 2020 Western Trauma Association critical decisions algorithm, which was published in the Journal of Trauma and Acute Care Surgery in November 2020. We are joined by the first author, Dr. Eric Ley, Professor of Surgery at Cedars-Sinai Medical Center, Director of the Surgical Intensive Care Unit, and Program Director of the Trauma and Critical Care Fellowship. Dr. Ley?
Thank you, Dr. Dhillon. It's a pleasure to be here. We're going to go over the appropriate treatment of VTE prophylaxis to decrease the rate of DVTs and PEs after trauma. This is a potentially preventable complication, and the rate of DVTs after trauma can be as high as 58%. Traditionally, patients were treated with enoxaparin 30 milligrams twice daily, as that was shown to be better than heparin sub-Q 5,000 units twice daily. We're moving forward with this dosing, and we'll soon be showing why we recommend dosing it enoxaparin 40 milligrams twice daily or more for some trauma patients. So the overview of our quick presentation today is going to be titled Forks and Things. We're going to go with the who, the when, the how, and then some special considerations. So the who. So our algorithm for the Western Trauma Association guidelines were for adult trauma patients. Of course, some children and post-pubescent adolescents require DVT prophylaxis, but that's within a different set of algorithms. Our recommendations is to provide VTE prophylaxis for most patients. Those who are ambulating, have minimal injury, and a short hospital stay may not require VTE prophylaxis. Our guidance with this algorithm is to give most patients VTE prophylaxis. So when do we start the heparin sub-Q or the enoxaparin sub-Q? Well, for low-risk patients, you really should try to make an effort to start most patients within 24 hours or even within 12 hours. Those patients with active bleeding, solid organ injury, TBI, or spinal cord injury might require longer than 24 hours before enoxaparin or heparin sub-Q are initiated, but certainly almost all trauma patients can have VTE prophylaxis started within 72 hours. So this is the most important slide of the Western Trauma Association algorithm. Here we provide guidance on who should be started on enoxaparin 40 twice a day, enoxaparin 30 twice a day, or heparin sub-Q 3 times a day. Please note that most patients require enoxaparin 40 twice a day or more. Those that require less enoxaparin, that is at 30 twice a day, are listed here, and those in renal failure or with the low creatinine clearance require the heparin sub-Q at 3 times a day. Please consider adjusting your enoxaparin dose by anti-10A level or weight, and in some patients who have platelet inactivity on TEG, you may consider adding aspirin. So very importantly, the continuous uninterrupted dosing of pharmacologic prophylaxis is very important. It's probably more important than the type of enoxaparin or heparin sub-Q you're using. Please try not to hold VTE prophylaxis before any surgery or for any procedure. If you do see a platelet drop, please consider HIT, although HIT is very rare with enoxaparin dosing and certainly does occur with heparin sub-Q. So, and lastly, increasingly we're finding trauma patients require pharmacologic prophylaxis after discharge. We've listed some of those patient populations here. We recommend discharging on enoxaparin 30 twice a day, although aspirin and the anti-10A inhibitors might be a future area that we can discharge patients on. We're also seeing a need for severely injured trauma patients to go back and have surveillance ultrasounds while they're hospitalized, as this will decrease the rate of PE. And in a few patients, you may consider an IPC filter, namely these are the patients who have a DVT or PE and are unable to be placed on anticoagulation. That concludes my talk. Thank you very much, Dr. Dhillon.
Thank you, Dr. Ley. Look forward to more editions of Forks and Things from the AAST Associate Member Education Committee.